Hello friends, welcome to my medical coding YouTube channel. Always my intention is to share knowledge and gain knowledge. In today's session, we will learn ICD-10 CM and PCS interview questions and answers part 1. This session will be useful for the coders who want to attend the interviews as well as the coders who are already working in medical coding. Our first question is: patient was admitted with 4 cm right renal cell carcinoma. The patient underwent a right robotic radical nephrectomy. Pathology findings indicate poorly differentiated carcinoma invading the renal vein and renal sinus. How is this coded? So basically here patient is admitted with renal cell carcinoma. Because of that renal cell carcinoma, patient underwent robotic radical nephrectomy. So nephrectomy means removal of the kidney. After removing the kidney, patient will send samples to the pathology. And pathology findings indicate that poorly differentiated carcinoma. How do you code this scenario? Here, our answer is assign only code SU64.1 malignant neoplasm of right kidney except renal pelvis for renal carcinoma with invasion into the renal vein and renal sinus. So basically, based on this answer, we need to code the main reason for the radical nephrectomy, which is renal cell carcinoma of the kidney. So here, even though patient is having invasion into renal vein and renal sinus, we need to code it as malignant neoplasm of the right kidney only. Next one, the patient had outpatient radical prostatectomy, means removal of the prostate gland with pelvic lymph node dissection for prostate cancer. So here patient has performed excision of the prostate as well as pelvic lymph node dissection also. Final diagnosis listed on the pathology report indicates lymphovascular invasion. However, it also confirmed that no tumor is present in the lymph nodes. How is this coded? So this question also resembles previous question and answer. Basically, here patient is having prostate cancer and patient performed prostatectomy, and also during the pathology report evaluation, pathology report indicates that lymphovascular invasion, and also mentioned that lymph nodes does not have any tumor. How do we code this scenario? Here based on this answer, we no need to code any invasion into other tissues. We need to code just prostate cancer. Basically, based on these two scenarios, we need to understand that for invasions, we no need to code any separate code. Next scenario, a patient with factor V Lidine went to MD office for comedine adjustment. As all of us know, comedine is the anticoagulant medication. When referencing mutation factor V Lidine in the alphabetic index, the coding professional arrives at code D68.51, activated protein C resistance. When referencing deficiency factor V, the coding professionals arrived at code D682, hereditary deficiency of other clotting factors. There is no default code for factor V Lidine without referring the terms mutation or deficiency. How is factor V Lidine coded? So basically here, if you want to code factor V Lidine deficiency, you have two types of index entries. Basically here we need to know how to code or which index entry we need to use for factor V Lidine. So what is our answer here? Assign code D68.51 activated protein C resistance for documentation of factor V Lidine. Here what is the reference for this term? Mutation in the index when factor V Lidine is documented. Factor V Lidine and factor V deficiency are two distinct conditions. So here you need to check mutation in the index, then you need to check for factor V Lidine, and if the documentation contains factor V Lidine and factor V deficiency, you need to code them separately as these two are distinct conditions. So here our correct code is D68.51, not D68.2. Next one. A patient with a fluid-filled cyst of the left leg above the gastrocnemius presented to outpatient surgery for removal. So basically here gastrocnemius means which is a muscle. So patient is having fluid cyst above the muscle. So he came in for outpatient surgery for removal. Patient is now diagnosed with fibrin associated diffuse large B cell lymphoma positive for Epstein-Barr virus. How is this coded? So here we need to code D47.G9 other specified neoplasms of uncertain behavior of lymphoid, hematopoietic and related tissue and code B27.09 gamma herpes spiral mononucleosis with other complications for FA-DLBCL of the left lower limb positive for EBV. Code B27.09 is assigned to specifically capture the EBV. So basically here we need to code two codes. One is for FA-DLBCL which is fibrin associated diffuse large B cell lymphoma as well as Epstein-Barr virus positiveness. Next one, a patient with left side facial weakness and numbness, left arm and left leg weakness, right tongue deviation, left eye photophobia and pitching on the left side of the face was admitted for possible stroke. So here it is possible, not confirmed. No stroke was found and the patient was diagnosed with left-sided facial droop / left-sided weakness secondary to complex migraine. Is it appropriate to assign code for hemiplegia when left-sided weakness is secondary to chronic migraine? How is this coded? So basically, these are the symptoms of stroke like facial weakness, leg weakness, tongue deviation, and eye photophobia and twitching on the left side of the face. Commonly, we will see these symptoms for symptoms in stroke patients. But after evaluation, patient did not find any stroke. But patient is having the chronic migraine. So here our question is, how do we code all these symptoms because of chronic migraine? So here our answer is assign code G43409 hemiplegic migraine not intractable without status migraneous for left-sided weakness secondary to CM since the provider linked the left-sided weakness to the CM. So how did the provider linked here? So clearly provided mentioned secondary to complex migraine. So here provided mentioned it as left-sided facial droop / left-sided weakness secondary to complex migraine. So here our underlying cause is complex migraine and manifestations are facial droops as well as left-sided weakness. And also a migraine is a type of brain disorder. This code assignment can be referenced in the alphabetic index as follows. So if you want to find this hemiplegic migraine, so you need to go to migraine, hemiplegic, not intractable, without status, migrainous, G43409. So and also if anyone looking for medical coding jobs in UAE, India and USA, please join in our WhatsApp group. So WhatsApp group link is in the description of this video. And also if anyone looking for same day surgery coding training, IPDRG training, SCC training as well as CCS certification training, please send WhatsApp message to 707-526-3939. Next question. A 77-year-old patient who recently underwent cardioversion for atrial fibrillation. So basically atrial fibrillation is the condition where abnormal heartbeat you can encounter in the atrial. Present to the emergency room with severe orthopnea and worsening dyspnea. Okay, so patient is having difficulty in the breathing process. The patient was admitted and diagnosed with new onset acute diastolic congestive heart failure, which the provider suspected was a consequence of the recent cardioversion. How is this coded? So basically recently patient had cardioversion for atrial fibrillation. After few days of the cardioversion, patient is had orthopnea as well as dyspnea. So after the evaluation, patient is diagnosed to have new onset acute diastolic congestive heart failure. How do we code this scenario? Here we need to assign I97.89 other post-procedural complication and disorders of the circulatory system not elsewhere classified, followed by code I50.31, acute diastolic congestive failure. This code assignment can be referenced in the alphabetic index as follows: complication, post-procedural, specified NEC, circulatory I97.89. So basically here, patient had this congestive heart failure due to circulatory system procedure. So here, first we need to code I97.89 as well as the condition which was the resulting of this circulatory system procedure, which is acute diastolic congestive heart failure. Next scenario, a patient with a recent history of cardiac ablation was admitted with heart palpitations with concern for recurrent ventricular tachycardia. So tachycardia means fast heartbeat. Multiple tests were performed, including an electrocardiogram, and the provider documented that the patient's symptoms were due to accelerated idioventricular rhythm without ventricular tachycardia present while symptomatic. When referencing the term rhythm in the alphabetic index, there is only one subentry for idioventricular, which leads to I44.2. AV block complete. This code assignment does not seem appropriate for this condition. How is this coded? So basically using the index, if you find in the rhythm in the index, rhythm as the main term, and under rhythm you will see idioventricular, which leads to I44.2. The code description for this I44.2 is atrioventricular block complete, but our condition is idioventricular rhythm without ventricular tachycardia. Okay, so how do we code this scenario? So now we need to code for AIVR. So assign code I49.8 other specified cardiac arrhythmias for AIVR. Code I49.8 includes arrhythmias, rhythm disorders that are not specifically classified in ICD-10 CM. Even though documentation contains I44.2, so basically here patient does not have any block. Okay, so here we need to code I49.8. Next question. A 74-year-old patient admitted with subacute cough, sputum production, and recent onset of fever, not response to antibiotic therapy. Okay, clear. So the patient had bronchoscopy which showed significant excessive dynamic airway collapse throughout the airway. There is no specific index entry for this condition. How is this coded? So basically, patient had cough, sputum production, and recent onset of fever, and patient undergone antibiotic therapy also, but which is not rectified the patient's symptoms. And patient had bronchoscopy which showed excessive dynamic airway collapse. Usually we'll call it as EDAC. So patient had collapse of the airway. So the code for this EDAC is J98.8 other specified respiratory disorder. We need to code whenever documentation contains EDAC. And also if anyone looking for free videos related to CPC, ICD-10 PCS and CPT, inpatient IPDRG, CPT modifiers, SCC coding, please use these playlists. These all are free videos. Whenever you have the time, you can learn this. Next question. A patient with cricopharyngeal muscle dysfunction has continuous upper esophageal spasms after eating. Okay, so patient already had cricopharyngeal muscle dysfunction, which is in the throat area. The patient also has regurgitation of the food without any functional limitations in the swallowing mechanism. So also because of this muscle dysfunction, patient had regurgitation of the food. The patient had EGD with balloon dilation of the cricopharyngeal muscle. How is this coded? So basically because of this regurgitation, patient has performed EGD and he expanded or dilated the cricopharyngeal muscle. How do we code this diagnosis? Here we need to assign K22.4 dyskinesia of esophagus for cricopharyngeal muscle dysfunction. This code assignment can be referenced in the alphabetic index as follows. So here patient had the spasm and you need to go into the alphabetic index as a main term as spasm, and under esophagus you will find K22.4. Next question. A patient is admitted with diverticulitis complicated by colovesicular fistula and prevesical abscess. How is this coded? So basically these are two or three conditions. We need to understand how to code these procedures or diagnosis. The answers are here. K57.20, diverticulitis of large intestine with perforation abscess without bleeding, and code K68.19, other retroperitoneal abscess. So diverticulitis. So inflammation of diverticuli is called as diverticulitis of the large intestine like colon with perforation and abscess without bleeding, and code K68.19, other retroperitoneal abscess for perivesical abscess. Vesical means basically kidney or prevesical abscess. So how do we find K68.19? Here in the index, main term as abscess and extraperitoneal K6819. And also we need to code vesico-intestinal fistula. So here vesico means bladder or kidney intestinal fistula. So the fistula is the abnormal opening between two structures. Okay, so vesico-intestinal fistula for the colovesicular fistula. This code is referenced in the alphabetic index as follows. Fistula colovesical. So abnormal opening between colon and bladder is called as colovesical fistula. Next one. A patient with iron deficiency anemia came in for an upper endoscopy. A few erosions were found in the duodenal bulb and biopsies were taken. The final diagnosis is chronic duodenitis with gastric foveolar metaplasia. How is this coded? So most of the time this type of diagnosis you will find in the pathology reports. Okay, so mostly you need to check for pathology report for like this diagnosis. So how do we code this one? So for duodenitis we need to code K29.80, which is for chronic duodenitis, and also for gastric foveolar metaplasia or GAFM we need to code R89.7, abnormal histological findings in specimen from other organs, system and tissues for GFM. So this is for PCS purpose. This is also PCS. Just you can read this one. You are able to understand the question and answer. So this Q&A also for ICD-10 CM PCS. So this is also PCS. You can understand this one if you read well. This is also PCS. You can read whenever you have that time. This is also PCS. Here also we have PCS question and answer. Now we have ICD-10 CM. So a patient with a left anterior acetabular fracture was admitted for surgical correction of the left ilium. Okay, so ilium basically in the pelvic area. A broken drill tip within the left ilium was noted as a complication in the operative report. The provider documented that the morbidity and risk of removing the drill tip from within the bone outweighed the risk of leaving the broken tip within the ilium. Is it appropriate to assign code T81.590A, other complications of foreign body accidentally left in body following surgical operation initial encounter for the retained drill tip of the left ilium? So here basically physician has performed the surgery. So during the surgery, patient or physician accidentally kept drill tip. So how do we code this scenario? Answer: do not assign a code for a foreign body accidentally left in when the provider intentionally leaves the broken drill tip in an effort to avoid subjecting the patient to the additional risk of removal. Okay. So code Y65.4, failure to introduce or to remove other tube or instrument should assign to report broken drill tip that was left at the completion of the surgery. So basically here intentionally in order to reduce the risk, patient kept the drill bit or drill tip in the ilium. Next one is a pregnant patient presents to the clinic for return obstetric visit. The patient's pregnancy is complicated by several conditions which were evaluated and managed during the encounter, including the chronic hypertension. So basically here, how do we code chronic hypertension in pregnancy? Here our answer is, it would be appropriate to assign a code from O10 pre-existing hypertension complicating pregnancy, childbirth and the puerperium when chronic hypertension is documented in a pregnant patient. So what is chronic hypertension? Which is a pregnancy is a synonymous with pre-existing hypertension. So basically both chronic hypertension as well as pre-existing hypertension are same. If there is no additional documentation regarding the specific type of hypertension, a code from O10.91 unspecified pre-existing hypertension complicated pregnancy is assigned. So if we have specified hypertension like chronic hypertension, we will code O10. If the documentation does not contain any type of specific type of hypertension, we need to code O10.91. Next question. An patient who was admitted for open reduction with internal fixation, usually if you go to interview, they may ask you what is ORA, of a hip fracture inadvertently pulled out their Foley catheter which resulted in hematuria. What are the correct code assignment for this case? Would this consider a complication of the catheter or a post-procedural complication? So basically here patient came in for ORF of the hip. During the surgery, patient has inserted the Foley catheter. So intentionally patient has removed the Foley catheter. Because of this removal of Foley catheter, patient had hematuria. So how do we code this scenario? So what are our codes here? T83.83 into A, hemorrhage due to genitourinary prosthetic devices, implants and grafts, initial encounter, and R31.9 hematuria. So basically in this example, patient sustained injury causing bleeding due to pulling out the catheter, not a post-procedural complication. So why not post-procedural complication? Here patient did not perform the procedure. Okay. So during the before the procedure only patient had pulled the Foley catheter. So therefore we will not code N99.820 post-procedural hemorrhage of a genitourinary system organ or structure. Basically here you need to check what is the time of the complication. So before the surgery, during the surgery or after the surgery. So here it is before the surgery. So we need to code T code. Next one. A patient with a past history of VPH was admitted for gross hematuria following catheter placement in the ED the day before admission. So patient had basically BPH. Because of this, patient had catheter placement. Okay, so after the catheter placement, patient had hematuria and he visited the emergency department. The patient was treated with continuous blood irrigation and had the catheter replaced. So because of this catheter complication, patient has replaced the catheter. The gross hematuria was found to be secondary to trauma to the prostate during the initial catheter placement. What are the correct code assignments for gross hematuria secondary to traumatic Foley insertion? How is this coded? So basically here patient is having hematuria after the procedure. So which is a post-procedural complication. So here we need to code N99.820 and also for specificity the complication we need to code R31.0. Here patient or physician clearly stating patient had hematuria secondary to traumatic Foley insertion. So which is a post-procedural complication. Next one. Patient complained of urinary frequency and urgency at night. The provided diagnosis chronic renal impairment stage 3A. Is it appropriate to assign a code for chronic kidney disease stage 3A when documentation states chronic renal impairment stage 3A? If not, how is this coded? So basically the question here is how do we code chronic kidney disease stage 3A and chronic renal impairment stage 3A? So query the provider to clarify whether the patient has CKD stage 3A. If CKD is confirmed, we need to code N18.31. If only renal plane impairment is confirmed, we need to assign N28.89. Okay. So here the important thing we need to remember is Chronic renal impairment is different and CKD is different. For chronic renal impairment, we can't code CKD code. Next question. A patient was admitted due to lower left quadrant pain. An MRI shows concern for possible osteomyelitis with pubic symphysis joint infection and surrounding bone marrow edema. The patient had a biopsy of the pubic symphysis. So basically here patient had osteomyelitis of pubic symphysis and infection, and physician has performed the biopsy. Pathology was negative for osteomyelitis. The provider listed osteitis of the pubic symphysis as the diagnosis at discharge. So during the pathology evaluation, patient does not have osteomyelitis, but pathology mentioned it as patient has osteitis. What is the correct diagnosis corresponding osteitis of the pubic symphysis without evidence of osteomyelitis? So we need to code here M89.8 into 8 other specified disorders of bone other side for osteitis of the pubic symphysis without evidence of osteomyelitis. Next question. A patient is evaluated for inflammatory arthritis of multiple joints. So patient is having inflammatory arthritis of multiple joints. Multiple means more than one joint. Can code M06.4 inflammatory polyarthropathy be assigned for a diagnosis of inflammatory arthritis when the specific joint sites and the types are not documented? So basically, how do we code here inflammatory arthritis? So can we code M06.4? That is the question here. So what is the answer here? The coding professional should query the provider regarding the specific sites and type of arthritis that the patient has. If no other information is available, assign code M13.89 other specified arthritis multiple sites. So here we can't code inflammatory polyarthropathy if the documentation does not contain inflammation. So next question is, how do we code inflammatory arthritis? As there is no index entry for inflammatory arthritis. So here we need to query the physician first, but if no other information available, we need to code M13.80. Next question. A patient with a history of a loop gastric bypass presented to the ED with abdominal pain and was found to have a perforated viscus at the gastrojejunal anastomotic site, which required surgical repair during the admission. Is this anastomotic perforation considered a complication of the bypass procedure? So basically, patient had morbid obesity. Because of that morbid obesity, he undergone gastric bypass or gastric restrictive procedure, and after the procedure, patient had gastrojejunal anastomosis. Okay, so currently patient had perforation at gastrojejunal anastomosis site. How do we code this procedure or diagnosis? Here we need to code K63.1 perforation of intestine for the perforation of the gastrojejunal anastomosis. It would be inappropriately report this condition as a complication of the gastric bypass procedure without provided documentation indicating it as such. As here physician did not mention this perforation is the complication. So here we can't code the complication. We directly need to code perforation of intestine. So thank you friends. So thanks for visiting my channel. If you like this session, please click on like button in order to motivate me to provide more videos like this. And if anyone looking for training, 707 526 3939 is the contact number.